Hello everyone, good afternoon. We're going to go ahead and get started. I have 12 o'clock and today our topic is the case for testosterone replacement. Many of you may have patients with androgen deficiency. Maybe you are managing testosterone replacement in some of your patients, and hopefully this talk will be a good refresher for you. Some of you are a little bit newer to that and this may be kind of an initial primer, and so we'll talk through this. I have built this around a case. The case in question is one of my patients. I've been caring for him for approximately 11 years now. So just an obligatory disclaimer and disclosure slide that because I am posting these videos on YouTube now, this presentation is intended for general education of medical professionals. It is not to substitute for the advice of a personal physician, and I have no financial interest or remuneration for the presentation. I won't be recommending any specific products today. I will mention a few brand names, but only for the purposes of comparing costs and what's available. So I'm drawing on two primary sources for this talk. One is an review article in the American Family Physician called Testosterone Therapy Review of Clinical Applications. This article was published in 2017, and it is an excellent comprehensive review of testosterone replacement therapy in the androgen deficient male. The second article is from the Journal of Family Practice. I really like how this article is constructed, and if you were to desire a little bit of further reading, would highly recommend either of these articles. And again, I particularly love the JFP article, does your patient really need testosterone replacement? So objectives today for the learner, I would like you to identify appropriate patients for consideration of testosterone replacement therapy. I would like you to accurately diagnose male hypogonadism, counsel effectively considering testosterone replacement therapy, including the potential risks and benefits, enabling your patient to make an informed decision. And lastly, to promote patient safety with appropriate monitoring of patients on testosterone replacement therapy. So with that, I'd like to jump into our case today. And the first case is Joe. Joe is a 44-year-old man, and this is an excerpt from the patient records. This was actually before Cerner, believe it or not. We were a clinic and took care of patients before Cerner existed. And this is from our previous medical record, and I've snipped it out. So the patient actually came in with a chief complaint of numbness in the hands. So obviously when you see this chief complaint and along with that, many other patients coming in with vague chief complaints, you kind of have to wonder, you're probably not sure what you're getting into. And plus, how does this relate to hypogonadism? As you continue to read through the HPI, the patient has been describing panic attacks, insomnia, lack of appetite, poor concentration and energy, and low sexual function, to name a few. So I gotta be honest, when I first saw this man, hypogonadism was not the first thing that popped into my mind. And for full disclosure, that wasn't really the whole picture anyway. But this is the initial presentation. On exam, when we see Joe, he presents with stable vitals. You'll notice that his weight is 297 pounds, almost 298 pounds. Joe's a big guy. He's about 6'7" or 6'8". He's just a really big guy all around. Otherwise, his vitals were stable. You'll note that his weight is down almost 9 pounds from previous admission or previous office visit. And so that was consistent with his history of reported loss of appetite. On exam, everything kind of checked out okay. There was no abnormality really apparent. So I made a diagnosis of major depression. And as you think back to that HPI, he was really hitting on a lot of those SIGI-CAPS criteria for major depression. I started him on sertraline at a dose of 50 milligrams daily. And I ordered some labs. You can see in the copy of the SNP out of the progress note that I ordered a comprehensive metabolic panel, a TSH, a total and free testosterone. And I requested to see the patient back within a couple of weeks. So here are the initial lab results that came back for this patient, Joe. His electrolytes were normal. His glucose was borderline high. His creatinine and other kidney functions were normal. His liver functions were slightly abnormal with an ALT and AST both in the 40s. Bilirubin was mildly elevated. His TSH was elevated at 6.6, and his total testosterone came back 135. You can see on the lab snippet here that it includes the reference ranges, and for testosterone, it lists a reference range of 300 to 1,000 nanograms per deciliter, and that is consistent with most commercial labs. So based on the presentation, would you consider testosterone replacement in this patient? How would you counsel Joe? And what should be done next? These are questions I'd like you to be asking right now. And I'm going to shift gears and away from the case and jump into a little bit more on hypogonadism. So hypogonadism refers to an androgen deficient state, actually can refer to either male or female, and it can refer to estrogen deficiency or to androgen deficiency. In this case today, we're centering on hypogonadotropic hypogonadism related to testosterone deficiency. And it's really defined as two things in combination. One is the presence of symptoms of low testosterone, and the second is confirmation of low testosterone, which means a biochemical evidence of low testosterone on at least 2 occasions. There are many symptoms and signs that hypogonadism can present with, and I'm going to review those on the next slide. And I want to make a case today that testosterone replacement therapy can diminish the symptoms and improve the quality of life in men with documented low testosterone and sexual dysfunction. Here's a list of several of the signs and symptoms of low testosterone in men, and they include low energy and vitality, decreased muscle mass and strength, diminished physical performance, hot flashes and sweats. I want to highlight on the second column depressed mood and decreased libido and erectile dysfunction. There are several other things listed on here, including changes in body composition. And one that I did not list on here is the sign of anemia. Anemia is commonly normocytic normochromic when it relates to hypogonadism, but in men with undifferentiated anemia, this is something to consider as well. So to make a diagnosis, I already kind of let the cat out of the bag that you need both symptoms and biochemical evidence of low testosterone. So you should measure the testosterone. And the most common way that we measure testosterone is with a total serum testosterone. This test is widely available and it's inexpensive and it's reliable, other than the fact that the testosterone has a marked diurnal variation, meaning that it is highest at certain times of day and lower at other times of day. The peak in testosterone generally happens in the early morning, although we know from very limited data for shift workers that it typically will peak as they are getting toward the end of their sleep cycle. So typically for shift workers, we actually test it within 2 hours of awakening. So it's very important to measure the testosterone in the early morning. In young men, the evidence would show that the testosterone level varies by about 35% from the early morning to the late afternoon when it reaches its lowest point. In older men, that variation is probably more like 20%, but it's still very significant. So I can't stress to you enough how important it is to measure the testosterone at an appropriate time. So again, you want to check that testosterone. We typically start with a morning serum testosterone level, and you want to repeat that at least a month later. It's very important to measure this on at least 2 occasions, and that is because of the variation that can occur with the serum testosterone. At the point that I'm rechecking the testosterone, so the second lab draw, at that time, I consider going ahead and adding in the FSH, LH, and prolactin. We'll talk a little bit more in a moment about that. And before I move on, I want to let you know that glucocorticoid therapy and opioids can affect the serum testosterone levels, and this can lead to inaccurate testing, and you have to consider that and maybe defer testing if you're able to, if this is a short-term treatment. So again, diagnosis, when you're working up testosterone deficiency, the question becomes, is this from a failure of the testicles to produce testosterone, or is this from a failure of the HPA axis? In some patients, the pituitary gland is the source of problem, and the testicles are normal in function. Causes of primary, meaning testicular failure, are Klinefelter's syndrome, which is XXY trisomy, orchitis, trauma, radiation, or chemotherapy, also undescended testicles. So those are the common causes of primary. Common causes of secondary hypogonadism include Kallman's syndrome, so the other K syndrome, and tumor, trauma, radiation, sarcoid, and tuberculosis. Pretty much anything that's infiltrative that would affect the pituitary gland. So when you are diagnosing patients with hypogonadism, at the point that you've confirmed that they have a low serum testosterone, now you're trying to figure out, okay, is this because the testicles aren't producing testosterone, or is this because the signal is deficient in stimulating the testicle? And in some cases, it's a mixture of both. So the key thing, and what the American Urological Association recommends, is to measure a luteinizing hormone, which is LH. And in a lot of cases in practice, people will measure both LH and the FSH. You honestly don't have to measure both. LH is sufficient, and that is going to help you differentiate. So if the testicles are the problem, and it's primary hypogonadism, then you expect that LH to be abnormally high because there's a lack of feedback signal from the testicle. That negative feedback loop here on the right is lost. I'm going to show you that feedback. It's right here. That is lost, and then the LH should increase to increase the signal to the testes. So if the LH is high, then you've confirmed primary testicular failure. If the LH is either normal, which is often the case, or if it comes back and it's low, then that signifies that the pituitary gland is the problem. All right, next slide. So there are several benefits of testosterone replacement when it's used appropriately. And I've included a table here just to show you a little bit, highlight some of the evidence. I will admit that there's a paucity of evidence in general. There's just not a lot of great randomized trials that were well conducted that included high numbers of patients to really draw sound conclusions. So most of this evidence is grade B or C. But we do know from a meta-analysis of 23 RCTs that the majority of them show benefit on libido, on sexual function with testosterone replacement, although as you can see, not every trial showed positive benefit. The benefits for erectile dysfunction are even more mixed, and the effects on bone density, there is some evidence that there's positive increases on bone density. Some studies show increased density for the hip, but not the spine. There really are no studies that show a conclusive decrease in fragility fracture, but we do believe that it increases bone density in men. There's mixed evidence for effects or benefits with regard to mood and depressive symptoms, and there's a growing body of evidence, although still small, on diabetes markers. How do patients with both testosterone deficiency and diabetes respond to that testosterone therapy, and how does their diabetes control, how is it affected by testosterone replacement therapy? There is a randomized trial that was conducted involving 857 patients with a new diagnosis of type 2 diabetes mellitus, and they were followed for 3.8 years. they basically separated these people. It was a separation of these folks. It's kind of actually a combination of a cohort study with a randomized trial, because they separated the groups into men who had normal androgen levels, another group of men who had low testosterone, and then of the group with a low testosterone, they randomized to one group receiving testosterone replacement therapy and the other group to placebo. And what they found is that the group with the normal androgen level and the group that was treated with testosterone replacement therapy had a lower mortality over the 3.8 years in the study as compared to the group that had a low testosterone but not treated or had received placebo. So all this to say, there's a lot of mixed data, and it can be very hard to assess what's really true and what the effects of testosterone replacement therapy are. And one of the things that the Choosing Wisely campaign emphasizes is that physicians should not prescribe testosterone therapy for men with erectile dysfunction and normal testosterone levels. And this is based on the fact that there's very low benefit shown in studies for treating erectile dysfunction. And the majority of men with erectile dysfunction actually have normal testosterone levels. So this slide shows a forest plot, and this is looking at cardiovascular risk of testosterone replacement therapy. This has been a very hotly debated topic in the literature, and something that probably as a clinician you've heard a little bit more about in the last few years. And the fact is, we don't really know if testosterone replacement therapy decreases cardiovascular risk or increases cardiovascular risk, but there's evidence pointing both directions. And so there's a study, for example, that I didn't include in here, but just to give you a sense for what's in the literature, there's a study that was published in JAMA a couple of years ago, and they measured the coronary artery calcium score and the measurement of the intima media thickness in the coronary arteries, and they compared two groups of men, those who were receiving testosterone replacement therapy and those who didn't. And the group that received TRT had increases in the intima media thickness, and basically they showed progression of atherosclerotic plaques related to or associated to testosterone replacement therapy. However, other studies like the one I just cited show a lower mortality among men with normal testosterone and among men treated with testosterone replacement therapy when they're deficient. So there's just a whole host of conflicting evidence. This forest plot shows a meta-analysis that was conducted in 2017, published in the BMJ. And the forest plot, if you look at the very bottom, shows that this larger black diamond right here, if you can see my cursor, and that shows that the risk of cardiovascular evidence favors that it's a little bit higher in the groups treated with testosterone. So this means that this suggests that testosterone therapy may increase cardiovascular risk overall, but as you can see, the diamond overlaps with the median line at 1, which means that it's not statistically significant. And when you look at the individual studies, there are some that fall on both sides of the line. And the main point I want to highlight here is if you look down, even though there are multiple RCTs included in this meta-analysis, that of each of these trials includes numbers of cardiovascular events that are anywhere from 0 to 3. So we're talking about a very, very small absolute number of cardiovascular events here. And for the entire meta-analysis, total of 9 cardiovascular events in the testosterone groups compared to 4 in the placebo groups. And that's where we're seeing a lot of the scatter and a lot of these mixed messages, because we're dealing with something that's not very common in light of testosterone replacement therapy. So there are some absolute contraindications. These are things that you want to file away and make sure that you're abiding by these prior to initiating testosterone replacement therapy, you want to make sure that your patient doesn't fit any of these categories. Number one, polycythemia. If they have a hematocrit that is greater than 54, meaning it's 55 or more, you don't want to prescribe testosterone replacement therapy. And this is because we know that one of the effects of testosterone is to increase the hematocrit, and that can lead to concerns for the risk of thrombosis. You also, it's widely considered a contraindication to prescribe testosterone therapy to patients with active breast cancer or prostate cancer. Some guidelines say that any history of breast cancer would be a contraindication to testosterone replacement therapy. This is a little controversial as well because there is no conclusive evidence that testosterone therapy increases the risk of prostate cancer. So this is also a little bit controversial, but one of the treatments for prostate cancer is androgen deprivation therapy. Patients are given Lupron that prevents them from making testosterone, and that has been shown to be an effective treatment for prostate cancer. So it is a rational thing to assume that testosterone might increase prostate cancer growth. With PSA, it is recommended by the American Urological Association to measure a baseline PSA prior to initiating testosterone. If that PSA is 4 nanograms per milliliter, if it's greater than 4 nanograms per milliliter, it's recommended to not initiate testosterone therapy and to refer to urology. Also, I included on here, even though certain guidelines don't include it, I've included a recent cardiovascular event, meaning within the last 3 to 6 months, and acute VTE. So again, there's no conclusive evidence to prove that testosterone therapy increases the risk of VTE, but in a patient with an acute clot, this is not the time to start testosterone replacement therapy. Relative contraindications would include a high hematocrit but under 55. So if it's over 50, between 50 and 54, you want to be very cognizant of that and monitor the hematocrit closely. I wouldn't recommend starting testosterone generally for patients with untreated OSA or uncontrolled heart failure. And we know that testosterone replacement will impair fertility because you lose the pulsatile nature that is very key to fertility. And so it's important not to prescribe it to men who are attempting to conceive. And then general guidelines recommend for patients with severe lower urinary tract symptoms, mainly defined by an International Prostate Symptom Score or IPSS score of 19 or greater, that you wouldn't recommend, we don't recommend starting testosterone replacement therapy. This is another forest plot. This is from the same meta-analysis published in the BMJ, and it shows impact on quality of life. Now that is admittedly a hard thing to measure, but again, just to show you that this forest plot does show that it favors testosterone replacement therapy as favorably improving quality of life. And I have seen this in practice. I do think that you can make an impact for your patients. So let's go back to the case. Let's go back to talk about Joe a little bit more. So if you recall, we had assessed Joe for testosterone deficiency and thyroid issues, as well as initiating treatment with an antidepressant, in this case sertraline. Joe had some initial improvement from the sertraline, and you've identified that his testosterone, serum testosterone, came back 135, was the original level, I believe. So what do we want to do next? Based on what I had taught on, we want to repeat his serum testosterone to ensure that that is indeed low. So upon repeat, his testosterone comes back and it's 135. I think the original was 135, this one's 136. So they're actually very consistent. That's not always the case. And because Joe is such a big guy and he's almost 300 pounds, I went ahead and got a free testosterone. And you can see that right here that the free testosterone level is 30 with the reference range of 47 to 244. So that is also low. In men with obesity or a variety of other conditions, sex hormone binding globulin will increase. And as sex hormone binding globulin rises, it irreversibly binds with testosterone, making it unavailable to the body. So this is something that can cause some diagnostic uncertainty. And a common scenario would be that you get a borderline testosterone. And let's say that if Joe's had come back and his testosterone total was 285, and you say, well, boy, that's less than 300, but it's not very much less. That's kind of borderline. Then the question becomes, well, what is the free testosterone? What is the sex hormone binding globulin? And in what you can see sometimes is the sex hormone binding globulin comes back elevated, and the free comes back normal. Then that's representing what's probably a normal physiologic state for that patient. In this case, both the total and the free testosterone are quite low, so that is very consistent with testosterone deficiency. You can see I measured his prolactin, which came back 4.8, and that is in the reference range, right in the middle. And the FSH came back 3.5 with an LH of 3.1, both in the normal range. So these combination of these laboratory values strongly suggest that this is a secondary hypogonadism that is not secondary or mixed, I should say, that is not strictly just primary testicular failure. So in 2 weeks follow-up, this is from time 0. This is from the initial presentation, the 2 week later follow-up. Joe says that he is feeling overall a little bit better. He's taking the sertraline daily. He's starting to notice a difference, especially in the last couple of days. And he's still having some panic attacks. And I was, I guess, really nice to him. I gave him a little bit of Ambien for the short term, and he's been sleeping much better. So at this point, we discussed the low testosterone, the repeated low testosterone, and I'm a little bit off, I guess, on my timeline because I repeated that timeline, repeated the testosterone values, I think was more than 2 weeks. Generally, you want to wait 4 to 6 weeks to repeat. But at any rate, we started him on some testosterone gel at this time, 2 pumps daily. Now, he comes back another couple weeks after that, and he is overall feeling fine in the mornings, a little bit more anxiety in the afternoons, and he is off the Ambien. He's now sleeping 6 to 6.5 hours a night, overall doing quite a bit better. So at this point, he is still having significant anxiety symptoms, so I increased the sertraline from 50 to 100. We continue with counseling, and we continue the testosterone gel that he started, and I plan to recheck a level in 3 to 4 weeks, and that's going to be the initial recheck since we started TRT. So here's that initial recheck, and now his testosterone, we've successfully lowered his testosterone to 122. So if you're confused, if you're scratching your head here, you're in good company because I was confused as well. And he was reporting some improvements with regard to his mood and anxiety, but really he said, the fatigue and the weakness and sort of that lack of strength and stamina are no better. And so based on this follow-up and the persistently low testosterone levels, we counseled about different options and available formulations, and we decided to make a switch from the testosterone gel to a different formulation. So let's talk about what formulations are available for testosterone and the goals of therapy. So first of all, the goals of therapy are to improve the symptoms of hypogonadism. That makes sense, right? That's the whole reason that we're initiating therapy. And the secondary goal is to target a serum testosterone level that's in the low to mid-normal range. Now, we typically see peak and trough with some of the formulations of testosterone, particularly the injectable forms. Those tend to be given every 1 to 4 weeks. And in between injections, you're going to see some peak and then a subsequent trough. And so typically when I have men on injections, I will tell them, get your lab drawn before the next injection. So I'm consistently getting trough levels. If they're using something like a topical gel, that is less concerning. You just want to make sure it's early morning. And so that's the two-part goals of therapy. So for monitoring patients on TRT, it is important to measure this total testosterone. One interesting anecdote, and this is a what not to do, is that a couple of the different studies that I read said that there was a large what do you call it, like a pharmacologic database study, a review of patients, and I forget how many patients were in this, but several thousand, I believe. And they found that up to 25% of patients who were prescribed testosterone therapy had not had a testosterone level in the 12 months prior to the prescription. So this is kind of a what not to do. This is a poor quality of care. If you're just prescribing testosterone to people who feel like they want it and not measuring or following the testosterone, that is not standard of care. You want to measure that testosterone and hematocrit at baseline, and then I do one at 3, 6, and 12 months after initiating treatment. If those are at goal, then I think at that point it's acceptable to move to annual measurement. The AUA guidelines recommend measuring the testosterone every 6 to 12 months. So if you have a guy that's pretty reliable, I generally move to annual. Also think about getting a liver function test and a lipid panel at baseline. We do know that testosterone can affect the lipid panel, but it tends to keep the ratio of good cholesterol to total cholesterol consistent. So it's not like a huge clinical change or a change of clinical importance, but it is something that is worthwhile to do a CMP and a lipid panel at baseline. And then lastly, you really want to think about PSA. Personally, I measure a PSA on all men that I am treating with testosterone replacement therapy. The USPSTF recommends against routine assessment of PSA in the general population, but this is a population that we're treating with testosterone replacement therapy. Again, there's no conclusive data that proves that it increases the risk of prostate cancer, but at the same time, I think it's prudent to follow it. And I always check a PSA at baseline and then annually, and I just lump it in with the testosterone management labs. If you see the PSA increase more than 1.4 nanograms per milliliter in that 12-month span, that's a good trigger to refer to urology. So let's talk about what testosterone products are available. At this time, there are a variety of those, although before you feel, hopefully you don't feel too overwhelmed by this table, I'm going to say that there's really a couple of things here that rise to the top that a lot of men use. And as you can see, as we get toward the bottom of the table, some of these things just become really cost prohibitive. For example, I've never had a patient use the transdermal patch or the buccal testosterone replacement because the cost is so high. And there are other factors as well that play into that. All the men that I've treated in the past have generally used either the injectable or the transdermal gel or the transdermal solution. So these are the ones that are going to be the most commonly used. The injectable testosterone is the least expensive, although this doesn't factor in the cost of syringes and needles. It is fairly cost effective. Testosterone cypionate is the most commonly prescribed variety of this, and I have a few men on this on a regular basis. I generally start them at 200 milligrams every 2 weeks. I have found that some men are very sensitive to the peak and trough effect, and when that's the case, they're going to come back and they're going to say, you know what, I feel pretty good until the last 3 days, and then I feel pretty horrible again. And then you have to make a decision with the patient whether you want to, and again, based on testosterone levels, whether you want to increase the dose or whether you want to increase the frequency. So I have one patient who does super well on 100 milligrams every week, and that ends up being the same total amount that I started him on, which was 200 every 2 weeks. We just increased the frequency. And I have another patient, including this case here, Joe, we're calling him Joe anyway, that he's such a big man, and I don't know if that's the reason, but he needs a little bit more, he ends up taking 150 milligrams every week in order to get to the level that he needs to be at. You can see there's an injectable form, testosterone indocanoate, which is a long-acting formulation, and once it's initiated, it can be given every 10 weeks. This is really attractive from the standpoint of timing. It is, you have to register for prescribing this. There's like a special registration in order to prescribe it, and it's not something that's available to the patient by prescription. So I didn't include cost data for that reason. I'm not completely sure on insurance coverage for this, but I do know that the urologists use this product. And so we can get more information about that. If you have a patient that you think is a good candidate for it, that's an opportunity to discuss with urology. The transdermal gels have now become generic. So there's generic available for androgel. The 1.62% is a very commonly used generic concentration, and the usual starting dose is 50 milligrams daily. The important thing to remember about the transdermal products, and this is something you must warn your patients about, is the possibility to transfer that testosterone gel onto other people or even pets. I read an article in some journal, it's been a year or two ago, I forget where I read it, that a pet was having all these problems, and came to find out that they were being treated inadvertently by testosterone when they were being held by their owner. So, you know, this can affect people and pets. Most concerning when you have a man using this who has young female children, because it can cause virilization. Another option that I did not include on this table are transdermal pellets, subcutaneous pellets that can be implanted, and those pellets are not widely used, but again, I think the urologists do use them from time to time. They last on average for about 3 to 4 months duration. So just to give you some idea of how that works. So Joe is not doing better on the gel. He's not had improvements. His testosterone has not increased at all. In fact, it's gone down. So one option would be to increase the amount of gel that he's using, try to just have him use more pumps. In his case, we talked about options, and he said, I really don't like that anyway. It's kind of sticky. And he decided he would prefer to just try the injections. So we switched over to injections. Again, the initial dose that I put him on was 200 milligrams every 2 weeks. And at that time, we continued the sertraline at 100 milligrams every day. So then I planned another follow-up with Joe in about 4 to 6 weeks. And we planned to recheck his testosterone again at that time. 4 to 6 weeks later, this is after starting the injection testosterone therapy. 4 to 6 weeks later, his testosterone level did come up to 238. That is still below the target we're trying to achieve, which is around the 300s or maybe 400s for our trough. And so at that point, Joe and I discussed his symptoms, and we decided to increase the dose. And again, I believe we went to initially, we might have went to 300 milligrams every 2 weeks, and that dose change was made. And then a 6-month follow-up was planned. So at that point, he is doing well. He notes that his strength and energy are much better. He's sleeping well, and he's still complaining of erectile dysfunction. So as you can see, testosterone replacement therapy does not fix every problem related to sexual functioning or male health. And in his case, he continued to have persistent erectile dysfunction, even despite using the testosterone therapy. He, on his own, had decided to decrease the sertraline from 100 to 50, and honestly had continued to do really well from a depression and anxiety standpoint. And it was kind of a reasonable thing, even though I tell patients not to monkey with their medicines, was a reasonable thing to do because of the erectile dysfunction, to see if that would improve. And it didn't. So mood stable, basically overall he feels pretty good. And so we continued him on that lower dose of sertraline. We tried a PD-5 inhibitor, and we kept him on the dose of injection testosterone. And that went on for years. In fact, fast forwarding about 8 years, as of 2019, Joe's doing really well. At this time, he's taking 1.5 mLs, which is 300 milligrams every 2 weeks, and he is feeling great. He has no concerns about it. He feels no adverse effects. And then I've included some of his labs here. These were done in April of 2019. You can see that his TSH has been creeping up, and in fact is now up to 9. And this was something that I've been monitoring on an approximately yearly basis. And his hematocrit is staying relatively stable in the upper 40s. So a couple of last points to make before we end is that testosterone therapy is not always indicated for older men. Many men over the age of 65 have testosterone levels below the normal range. In fact, men over the age of 50 can have testosterone levels below the normal range. There's one study that looked at men at the different ages, 50, 60, 70, and 80, and they basically assessed testosterone levels, and they found that for the men in the cohort of 80 years and up, that was actually 49% of those men had testosterone levels below that so-called normal range of 300 to 1,000. This suggests that there's a certain element of normal decrease that comes with aging. We know that the total testosterone will decrease starting at about age 40, and it goes down by about 1 to 2% per year. And the free falls by about 2 to 3% per year. So you have to be very cautious in assessing the testosterone in an older male in deciding whether or not it is truly low and merits testosterone replacement. So if you have an older man, say 65 and up, generally wouldn't recommend offering replacement unless the total testosterone is below 200 nanograms per deciliter. And again, the role of symptoms and signs is important here as well. So we've been focusing a lot on men today, and I do want to talk just briefly about testosterone therapy in women. We know that the testosterone deficiency in women can be associated with problems including sexual function, mood, cognition, and body composition. And this is the same for men and women, all of these things. There was a comprehensive meta-analysis, and women, postmenopausal women, found to improve sexual function with testosterone therapy. There was no evidence for improvement in anxiety, mood, body weight, body mass, or bone density. The Endocrine Society and American College of Obstetrics and Gynecologists both support the use of testosterone therapy for hypoactive sexual desire disorder in postmenopausal women. So that's kind of the one area, the one indication where testosterone therapy is kind of supported in women. But it's important to note that there are no FDA-approved products for therapy in women, and there are no commercially available products, so it would require going through a compounding pharmacy. So choosing wisely has a few recommendations for us, and I think it's important to highlight these before we end. And hopefully I've already touched on these throughout the talk. Number one is do not prescribe testosterone therapy unless there is laboratory evidence of testosterone deficiency. This is not a fountain of youth. It is not for treating patients who just feel like they need a little boost or need to enhance their performance. This is about replacing something that is biochemically deficient, and that's an important component of the diagnosis. Number two, do not prescribe testosterone therapy to men for erectile dysfunction who have a normal testosterone level. It is not a treatment for ED. In men who have ED, about 20% of the men with ED may have low testosterone levels. And in the right patients, testosterone replacement therapy may improve erectile dysfunction, but the data were mixed. And number three, do not prescribe testosterone to men contemplating or attempting to initiate pregnancy, because it is going to impair that. So bottom line, testosterone replacement works when used properly. And by carefully selecting which patients that you assess for hypogonadism, you can best decide who to treat and how to improve quality of life. Symptoms of low testosterone are very common, but they're not specific. So you're going to see so many men with fatigue, with lack of stamina, with general feeling of unwellness. And it can be hard sometimes to decide when to screen for low. It's not really screening, it's a diagnostic test, but when to assess for low testosterone and when to not. And it's really hard to give you a one-liner answer for that. Number 4, when symptoms suggest low testosterone, make sure you confirm that diagnosis with a second occasion, with a test on a second occasion. And lastly, when you do measure testosterone, again, I can't stress this enough, make sure your patient is doing it at appropriate time of day within 2 hours of awakening, generally before 10 a.m., unless it's a shift worker. So I have a few references. There are several articles here that I pulled from. There were many more available. I really tried to select the highest yield articles. The 2 that I put in the initial slides, the one from an AFP and the other from the JFP, were excellent review articles. So if you want more information, I would recommend that you read those 2 articles. And then the link included here at the bottom reference is the American Urological Association. They have a treatment guideline for testosterone deficiency. And at that website, there are videos available that outline and highlight the guidelines.